Sebentar, guest speakers-nya udah masuk belum ya? Atau belum?
Seperti nanti mereka join saat diskusi, Dok.
Oke. Oke. Ini Indonesia dulu aja atau langsung?
Indonesia aja juga nggak apa-apa, Dok.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Okay, thank you very much for the joining for the program of International Surgical Webinar. Good evening, professor, teachers, and colleagues. Today, we would like to discuss further about chronic pelvic pain syndrome. As all we know, CPPS is one of remarkably interesting topics in manhood, and it is also hard to explain with various symptoms and quite often in daily clinic. Now, let me introduce one of our distinguished speakers today. The first speaker is Dr. Gede Wirya Kusumaduarsa. We call Dr. Wirya. Good evening, Dr. Wirya.
Good evening, Dr. Ricky. Nice to
Okay,
meet you.
Dr. Wirya is one of our well-known urologists in Denpasar General Hospital Denpasar. Dr. Wirya now will talk about the ethic and patient safety in andrology urology service. Okay, I think for the time being, Dr. Wirya, time is yours. Thank you very much.
Thank you, Dr. Ricky. Please.
Okay, Dr. Wirya. Excuse me, I can't hear the voice, sorry. Okay, we're still waiting for the broadcast. Sorry for the technical issue.
Colleagues, I'm Gede Wirya Kusumaduarsa from Sanglah General Academic Hospital,
All right.
Faculty of Medicine, Udayana University. As the President of Indonesian Society Andrology Urology, I'm most happy to welcoming you all in this CIOMS webinar that was well organized by Dr. Widyat Moko, urologic consultant of andrology, and hope that you will all enjoy the meeting. Best regard and thank you to Professor Nickel and Professor Sox for the lectures. And please be welcome to the next Becoming Offline meeting in Indonesia. And thank you for Mr. Chairman and the committee for giving me a chance to deliver the speech about the ethic and patient safety in andrological urological services. I'm going to break down my talk into three major topics: the science, ethical issue, and patient safety, and special cases in andrology urology. The science point of view regarding that there are a lot of new advancements in this field that need to be controlled by the ethic in order to achieve patient safety. For example, in IVF, ED, and also male family planning, there are new medicines and surgery technique to be supervised by the ethics. The ethic of the medical profession began to be known since 1800 before century in the form of Code of Hammurabi and Code of Hittite, and the World Medical Association by the Geneva Declaration in 1968 was performed the doctor's oath that used by the world, and the International Code of Medical Ethics, which contain of obligation toward patient, obligation towards others, and obligation toward oneself. The Code of Medical Ethics have several aims. The main and the foremost is to protect the patient's safety. Therefore, some questions rose up in the terms of the medical ethics, such as, is that new medicine or that new technique or that new equipment effective, or is it safe? And is it safe for the long run? And would there be unpredicted possibility of side effect? And how do we know that something was going wrong or going to be going wrong? Better research provide better health. And because good medical services are based on good evidence of studies. As we can see in this slide, that good research make good evidence, and evidence-based healthcare, and finally comes to better health status. At the right side, we can see the pyramid show the level of evidence starting from in vitro and animal study, and then human subject research with reliable evidence. According to the Council for International Organization of Medical Science, CIOMS, there are three principles of good ethics: beneficence, justice, and respect, which breakdown become two standard, as we can see at the slide: social, again, scientific value, scientific validity, fair subject selection, and risk, favorable risk to benefit ratio, and review in independency, monitoring and evaluation, and of course, respect the autonomy. Principle of human research ethics are autonomy, which are freedom to make choices for the patient, for the peoples. Non-maleficence mean premium, no necessary, or first of all, do no harm. Justice, so uphold equality for all patients, and good deed, beneficency. And of course, all these things were controlled by the altruism, means professional services. International Council for Harmonization of Technical Requirement for Pharmaceutical for Human Use, ICH, and GCP conclude that the treatment should be conducted in accordance with the ethical principles, Declaration of Helsinki, good clinical practice, and applicable regulation. And the treatment should benefit better than the risk. And safety, well-being of the subject, patient safety, adequate information for the treatment, and informed consent and confidential. All information should be recorded and handled and stored, and accurate reporting, interpretation, and verification. Confidential of identity of the subject. And the last one, all of the system of procedure assure the quality in every aspect of the trial. According to the Indonesian rules that published by the Minister of Health of Indonesian Republic 2010, there are 7 standards of patient safety. First is the patient right. The second one, the educating patient and families, patient safety and continuity of care, use of the performance improvement method to conduct patient safety, evaluation, and improvement programs, the leadership role in improving patient safety, educate staff about patient safety, and communicating is the key for staff to achieve patient safety. And doctor's character should be objective, honest, full of integrity, and full of understanding. The development of modern medical science make the existing medical purposes face challenges, especially in urology field, which are included organ transplantation, andrology, and reproductive, which are all very, very sensitive to ethics. WHO set up 3 goals to evaluate the health system performance. First, the improvement of health degree, the reactivity of the crowd expectation, and the last one, F for financial burden. Now there are 5 issues in andrology, urology that I'm going to discuss. First is the IVF. According to the religion, we can see the argument and insight from religion. Church said that there are 3 main rules. First, an embryo possesses the same right to life and integrity as a human being at the moment of fertilization. A husband and wife may only procreate with one another in natural sexual union, so ERT are not permitted. Additional, masturbation is deemed morally unacceptable in church. Buddhism does not have specific rule on ART. It might be allowed. Muslims said that IVF and ERT are fully tolerated in a husband and wife within a marriage. Donor egg, sperm, embryo are considered adulterous and prohibited. Embryo cryopreservation is allowed but should be destroyed if the marriage were to end following divorce or death. Prophet Muhammad said that for every disease, there is a cure. So, if you think that the infertility is considered as a disease, so it is acceptable to use medical technique to fix it. And Hindu in Yoga Sastra, Hindu tradition places a special importance of family planning, childbearing, and having children, especially having boys. ERT and IVF are accepted for family building. Sperm donation, adoption, surrogacy, and paternal surrogacy have been identified in the Hindu narrative and worldwide discussed in Hindu forum. The moral depravity of the IVF technique is caused by, first, the IVF is not the natural process that God created. The high failure rate of ET, where we all know that the success rate of the IVF in between 30 to 40%. The embryo that produced and frozen and stored in cryopreservation, many people said this is morally bad. The dignity of the children and parents makes there should no room for dominating for precision biology or technology. Number 1, children have the right to be conceived, developing in the womb is through a safe and recognized relationship, and child can find his identity and achieve his human development. Number 2, the essence of the marriage as a unity, the dignity of husband and wife, the value of marriage. So the child's right to be present in the world in a marriage through marriage. The other moral depravity of IVF technique is the raise of healthy children with IVF. The embryo who has the genetic disorder in the antenatal genetic diagnostic should be destroyed or used for research, and the possibility of the occurrence of incest. What about IVF in Indonesia? Indonesian health law in 2009 allow termination pregnancy when a serious congenital is there. And IVF is legal as long as the sperm and the ovum come from a legal marriage. And the finished fetal embryo is put back into the wife uterus. Sperm and eggs cannot be exchanged or even receive donation. Government effort to regulate the childbirth and pregnancy, distance and ideal age of delivery in accordance with reproductive right, where we hope that we will develop better human quality. In Indonesia, family planning was started in 1970 and has its up and down until currently. At first, its existence has been questioned by some mass organizations that said birth restriction is a violation of human rights, result in the killing of unborn baby, and can even expand prostitution and undermine the moral of society. several programs offered by the government years ago until now. The traditional way, hormone manipulation, intrauterine device, permanent contraceptions like tubectomy and vasectomy. And of course, because this is about human right, then we have to perform the informed consent. The family planning was regulated by Indonesian law. In Bali, family planning data in 2015 show that the acceptor of male vasectomy, male permanent contraception in Bali came from the middle class population and middle educated people also. And most of the patients already have 3 to 4 children before they decide to perform the vasectomy. This is our data in Indonesia, in Bali. Ethical issue in male sterilization in developing countries. So first of all is the religious issue. Buddhism and Hindu no text about prohibiting contraception. Christianity and Judaism no specific edict prohibiting, but Roman Catholic contraception was prohibited as it preclude the procreation. At the right side of the slide, you can see that there are 11 of us who signed a paper that we are able to perform the vasostomy for vasectomy patient who would like to have another baby. And this is the picture of the 5 temples in Bali from Muslim, Christian, Buddhist, and Hindu, which were built in the same area. So the toleration here in Bali. And the second ethical issue of voluntarism. Couples have the basic right to decide freely and responsibility the number and spacing of their children. Laws and regulation. Some countries prohibit sterilization, while other countries have sterilization program like Indonesia. You can see at the low picture, this is me who was given award by the government because of doing vasectomy more than 10,000. So, counseling and informed consent must not be biased toward of any specific contraceptive methods and facilities. You can see at the right side of the slide pictures. Should we do the vasectomy in hospital or in primary healthcare, or can we do the vasectomy in the mobile car like this picture? This is also should be discussed. And eligibility requirement, minimum age, minimum number of children, marital status, and spousal consent. In Indonesia, there is no minimum age, but we have to have a minimum 2 children, and the youngest boy should be more than 2 years old in legal marriage status, and we have to have a spousal consent, so from wife consent. Ethical issue in the future. The example is, should we perform the cryopreservation or for the sperm before we do the vasectomy, or should we do the egg cryopreservation before we do the tubectomy? This is an ethical issue in the future. Potential reason on doctors to be sued by a patient after vasectomy treatment, such as failure of the operation because it might resulting in unwanted pregnancy, significant post-op hematome infection requiring additional intervention, persistent chronic scrotal pain, atrophy of the testicle, and failure to inform a positive post-op sperm. In order to avoid such issue, the consent must be clear and including all aspects regarding the treatment and the side effect that could be exist after the treatment. Good example of consent for sterilization can be seen in the box 1. Ethics in fertility preservation in adolescent patient with cancer. Cryopreservation of sperm should be offered whenever possible. Fertility preservation should be considered experimental and offered in the setting of research protocol. This is a research protocol. To preserve child fertility, parents consider child assess. And the disposal of stored gamete, embryo, or gonadal tissue in the event of the patient's death or other contingencies should be legally outlined by all parties. And concern about a resultant of offspring with the future cancer risk. And the last one, of course, the culture and religion point of view should be considered. American Society of Clinical Oncology Clinical Practice Guideline said that we have to focusing in 3 questions. Are the patient interested in intervention to preserve fertility? What is the quality of the evidence supporting PF option in male? And what is the role of the healthcare providers in advising patients about FP option? The ASCO has published the guideline on FP in male cancer, and we can use this guideline as a way of deciding and discussing the problem on patients with such cases. The other ethics problem is in erectile dysfunction and penile prostatic surgery. 50% of United States men more than 40 years old have some degree of ED. The ethical issue of the ethical issue are men who did not need it may rush to buy and thinking that they might have benefit from that one. And some men might take a huge dose. And the last question, who should prescribe it? Urologists, andrologists, or family doctors? And X to overcome the issue, first, ensure the public that the drug was intended for a specific problem and address the issue to overuse via education, packaging, and marketing. And every doctor who competent as a medical worker for the erectile dysfunction may prescribe this medicine. Recent literature reporting that even the doctors treat the patient differently when it comes into penile prosthesis treatment due to the ethical problem. For example, this is the chart showing that likelihood of doctors offering penile prosthesis surgery. Sex offenders is 0.36 less likely to be offered penile prosthesis as compared to patients with refractory ED. That we know that this is the gold standard for penile prosthesis. So ethical principles should be appropriately applied by urologic prosthetic surgeon when ethical challenges arise. So again, we have to be concerned about good deed, freedom to make choices, do no harm, and uphold equality. And all those things are driven by good professionalism of us as a surgeon. What about ethic in circumcision? Some people oppose the circumcision. These are 297 publications included. This study ended up in a conclusion stated that all critical statements opposing male circumcision were coming from the low quality of sources. One of the issues that's still in controversy, does the circumcision procedure decided by the parents or the children themselves? So it should be also a concern also by surgeons. So as a take-home message, many of the ethical, patient safety, and policy issues in andrology, urology field. Consideration of this issue is scientific and biotic aspect, the minimization of risk and harm, the importance of information disclosure and informed consent, the potential of over-promising, over-expectation, and traffic misconception, and the pressure from commercial entities. Moving forward with the right blend of creativity and caution is essential in the interest of both science, ethics, and patient safety. Thank you. Thank you to Dr. Ida Bagus Putra Pramana and Pandey Wade Wisnu Tirtayas, MD, PhD, for the help. Thank you.
Okay, what a nice presentation about all aspects of legal and illegal aspect from the urology services, andrology, urology services. Yes.
Thank you, Dr. Thank you.
Okay, Doctor. I also would like to say good evening to Professor. Welcome also to Professor Jack Curtis Nicol. Thanks for joining for today webinars. Okay, I think we should go to the next presentation. Just the discussion will be later. The next presentation is, wait a minute. Okay. The next presentation will be delivered by Professor J. Curtis Nichol. Professor J. Curtis Nichol is also a urologist from Queen's University, Kingston, Ontario, Canada. He's one of the well-known researchers in urologic, pain, and inflammation. Today, Professor J. Curtis Nichol will deliver a nice presentation about understanding CPPS, chronic pelvic pain syndromes. Evaluation of the patients is the key to management. Professor Nichol, time is yours. Thank you.
My name is Curtis Nichol, and I'm Professor of Urology at Queen's University in Kingston, Canada. It's an honor to be invited to provide a lecture on chronic prostatitis, chronic pelvic pain syndrome for the Indonesian Urologic Association meeting for this year. I'm going to give the first part of a two-part lecture, being followed by Dr. Danny Shoskis, and I'm going to try and provide an understanding of who the patient is with chronic pelvic pain syndrome and try and persuade you that this understanding and subsequent evaluation of the patient is the absolute key to management of this difficult situation or medical condition. Now, traditionally, we have always thought of prostatitis as an inflammatory disease. The name itis, prostatitis, prostate, in the prostate. And we always felt it was organ-centric, inflammation in the prostate gland. And for decades, maybe even a century, we believed that inflammation was due to infection. That made the understanding of prostatitis simple. It was an infection of the prostate gland. And then treatment for decades was so simple. It was antibiotics for the infection and anti-inflammatories for the inflammation. Well, we now know that it's more complicated than that. About 10% of patients presenting with prostatitis may in fact have a bacterial infection causing inflammation and pain, and this simple strategy will work. But for 90% of the patients diagnosed with chronic prostatitis, chronic pelvic pain syndrome, it's not that simple. And I've had to learn this difficult lesson over the last 3 decades, and I was taught this lesson not only from our clinical research, but from the over 2,500 men who individually visited me for evaluation and treatment in our chronic prostatitis clinic here in Canada. Now, as you can see, that the literature in chronic prostatitis has ballooned over the last 2 decades and been pretty standard ever since we developed the National Institutes of Health classification, developed the Chronic Prostatitis Symptom Index as a validated way to measure symptoms at baseline and over time, and started to understand that patients can be individualized based on their phenotype. And I throw out UPOINT, which I'll talk about a little bit later, as a way we can phenotype patients with chronic pelvic pain syndrome. So I would like to provide a couple of insights. And one of them is that it may not be all about infection, or as we're learning more, maybe infection is in fact involved. You see, I started my career in microbiology 35 years ago, and my goal was to find the putative bug, the infection that caused all chronic prostatitis. Never been able to do that with the techniques and technology we had decades ago, such as culture and even electron microscopy, such as this particular picture, but we did learn a lot. We learned that bacteria can be in the prostate gland and reside there for years in a bacterial biofilm in the prostatic ducts and acini, protected from antibiotics, sometimes like in the bottom right picture, in a fossilized bacterial colony, an infection stone. These bacteria are sort of hibernating, cover themselves with a biofilm glycocalyx that protects them from host defenses and antibiotics, and they can persist and cause recurrent urinary tract infections and be resistant in between to antibiotic therapy. At one time, I believed that this might be the cause of all chronic prostatitis, but I've been sort of proven wrong. And a paper that we published quite some time ago looked at all the studies using traditional, non-traditional, non-culture techniques, and we determined that about 50% of the studies indicated that microorganisms might be implicated, and 50% were pretty sure that microorganisms were not implicated in chronic prostatitis. We didn't have the technology to look at this properly, but we did, with extended cultures, determine that in chronic pelvic pain syndrome, those patients without obvious infection or recurrent urinary tract infections had the same culture bacterial microbiome in both chronic prostatitis patients and healthy control patients with no symptoms. In fact, 8% of chronic pelvic pain syndrome patients, those without recurrent infection, had 8% had uropathogenic bacteria such as E. coli, Klebsiella, Pseudomonas grown in extended cultures of their expressed prostatic secretion or post-prostatic massage urine, but the same number of normal healthy subjects had this same bacteriological profile. In fact, when we use next generation sequencing, we see that the microbiome of the prostate is quite complicated. We're able to determine 78 different species and 48 genera using a very early type of next generation sequencing, but we were not able to show major differences, such as shown in this heat map, between the light blue on the top, which is normal controls, and the dark blue on the bottom, which is prostatitis patients. They looked very similar. We did see a number of potential candidates, one being this Burkholder Cenepipacea, but the evidence, even for this bacteria, was very slight, even though there was a significant difference. Whether or not this is a clinical candidate or a bystander, we don't know. What we have found using the most sophisticated next generation sequencing, where we can do the whole genomic sequencing of the bacteria, is that the lower urinary tract is a microbial jungle and is extremely complicated. And the interaction between the different bacteria in the microbiome may in fact impact disease and health. We just have to untangle this jungle and figure out what's going on. The second insight, and most of you already know that if you're practicing urologists, is that chronic pelvic pain syndrome is very prevalent and is associated in patients with a significant impact. In fact, the prevalence of prostatitis is similar across the board, whether we look at population-based studies, physician diagnoses, or patient self-report studies. About 7% of patients over the course of the year will have some sort of prostatitis-like symptoms. A third of them severe enough that they might mention it to their family physician or complain of the symptoms. Most of these are quite mild. Many of us have probably experienced these symptoms over our lifetime. In fact, studies have shown that 16% of even physicians experience prostatitis severe enough to be diagnosed with the condition over their lifetime. Now, it's not just a Western disease. We see the same prevalence in North America, Europe, Asia, Australia, and even Africa. So it's not just a Western disease we made up. These are symptoms that are across continents, across ethnicities, and across the world, in fact. And the impact, Well, the impact we know now, particularly since this occurs in younger men in their 30s and 40s, the social economic impact is similar to a young man with insulin-dependent diabetes or active Crohn's disease. And an older man, it impacts as much as having congestive heart failure or a recent cardiac event. A third insight, and I'm not going to spend a long time with this because we've already talked about the bacteriological etiology, is a little understanding with what's going on helps us figure out what's going on with the patients and direct therapy. Now, this particular slide is quite complicated and is a whole lecture in itself. But what we believe is going on is something happening that triggers inflammation and or pain in a susceptible individual. And that could be an infection, it could be trauma, it could be voiding dysfunction, it could be pelvic floor dysfunction, or it could be disease in an adjacent organ or even systemic disease that causes inflammation or neurogenic pain in the pelvis or prostate that is perpetuated by the endocrine system, immune function, the neurologic system, suprasensorial psychological impact, and we end up with a type of neuroinflammatory pain syndrome. It can be peripheral, it can be systematic or central, and it's all interrelated. So it's quite complicated, and every patient seems to have a different path to get to the symptomatology they present to us. Now, the fourth insight to understanding this is the evaluation is not as onerous or as difficult as we thought. What we want to do is classify the patient as non-infectious and diagnose them as chronic prostatitis, chronic pelvic pain syndrome, and then determine the patient's clinical picture or phenotype. The best way we have found in our clinic is to use the 9-question chronic prostatitis symptom index. It takes the patient 5 minutes to complete and allows the patients to explore the pain, which is the most impactful, the location, the frequency, and the severity of the pain, the storage and voiding urinary symptoms, and they'll be able to describe in this, by checking off boxes, the impact and the effect on their quality of life. This is what they want to tell you in the clinic, and they're able to do this with this form, and you'll have an idea of where their symptoms actually are. You must talk to the patient, but I always talk to the patient once I understand their pain, their urinary symptoms, and how it's impacting them by quickly looking over the CPSI they just completed. But talking to the patients allows you to get an idea of what is actually going on. And importantly, you have to examine the patient. It's amazing how many times this is actually missed. We'll talk about the examination in just a second. You have to rule out infection, and that's using differential cultures, and we'll talk about the pre and post massage cultures. And then there's all the other stuff that urologists can do, ancillary tests, radiologic tests, and the like. And that is indicated, not in all patients, but in some patients. The urologist has the best trained finger in medicine. We can use this finger to determine the tone and discomfort in the pelvic floor and perineum. We can determine if there's myofascial pain, trigger points of pain outside the prostate. And once we've determined that, then we check the prostate gland. But we do this examination after the patient's given us a midstream urine. Then we check the prostate and determine tenderness, only using the same type of pressure that you would do for a DRE looking for prostate cancer or evaluating BPH. But then you do a prostate massage. You use firm pressure on the prostate and expel some prostatic secretion into the posterior urethra. Sometimes it drips out the urethra itself. And then you have the patient obtain the first 10 cc's of urine, the VB3 or post-massage urine, for culture. And the 2-glass test will show you if there's infection hiding in the prostate If the post-M specimen has more, as any uropathogenic bacteria, or more uropathogenic bacteria than the pre-M specimen. This is a very good screening test and is easier to do than the old Mir-Stamy 4-glass test. Now, why would I put out a weather map of North America? That's North America during showing weather patterns. The circle is Kingston. And what I want you to think about is the weather in Kingston is impacted by the weather surrounding us and the weather that's moving in and moving out. And we end up with these beautiful color weather maps. Well, we see the same thing in prostatitis and chronic pelvic pain. We tend to focus on the site 16. Site 16 is the prostate pelvic area, but in fact, the pain the patients experience is also impacted by pain in the abdomen, in the back, in the head, and elsewhere in the body. Same as the weather impacts the weather in your local area, the pain elsewhere or beyond the pelvis also impacts the pain in the pelvis. Now, while this has a higher impact for some reason in the female gender than the male gender, it's still an important consideration that you must look beyond the pelvic organs to be able to certainly understand the patient. Now, other tests are sometimes necessary, but not always in the typical patient. Certainly, voiding cystourethograms can be helpful, looking, as you can see there, for bladder neck obstruction or detrusor sphincter obstruction with a blown out prostatic urethra. Urodynamics can help determine if the patient is obstructed. Ultrasound, CT scans, and MRI can find abnormalities of the prostate and the pelvis. And cystoscopy can help you look for abnormalities of the prostate, the bladder neck, and the bladder that may be a part of these symptoms. I don't usually do these examinations unless I'm confused about the presentation or the patient is not responding to my individualized primary therapy program. Now, insight 5 is every patient is different. You have to determine the clinical picture. Danishofsky's and I came up with this concept of the 6-point UPOINT, basing it sort of on the snowflake, something that we see probably more in Canada than you do in Indonesia. But a snowflake, almost every snowflake is believed to be slightly different than any other snowflake. But in fact, they're all similar with 6 points. And we developed this phenotyping UPOINT, where the different phenotypes that we believe are important and are driving this condition are urinary symptoms, psychosocial impact, organ centricity, such as the bladder, the penis with sexual dysfunction, or the prostate itself, infection in a certain percentage of patients, the neurogenic systemic pain that we see with the neurogenic pain and widespread systemic pain, its impact, and tenderness, and by that I mean tenderness and spasm in the skeletal muscle of the pelvic floor, but could also be in the groin and the abdominal wall and pelvic wall. Now, what we find is we look at the number of positive domains, and we see that only about 1/5 to 1/4 of the patients only have one domain, and that one domain, of course, is going to be the prostate. So chronic pelvic pain, chronic prostatitis, only 1/4 of the patients only have their pain and their problem limited to the prostate, while 75% or more have other domains that have to be addressed. And you can see that the more domains the patient has, like look at the poor patients with 5 or 6 domains, about 1 in 10, those patients have a higher CPSI score. So in fact, they have more pain, urinary symptoms, and worse quality of life, and it impacts more on them. The longer the patient has the symptoms, the more domains they develop. So there seems to be a phenotypic progression over time that's not related to age. And you can see younger or older dichotomized at 45 years didn't seem to make a lot of difference. Now, what's important for urologists is the domains outside the prostate appear to have the highest impact on quality of life and activities. And those are the psychosocial, the neurogenic systemic, and the pelvic floor dysfunctional pain may have more impact on the patient than the domains that urologists tend to look at more, which is the urinary, the organ-specific, the prostate, and infection. That's what we like to treat, whereas these other domains we sometimes ignore to the detriment of our patients. So what have I really learned over the years? Well, what I've learned is that chronic pelvic pain syndrome or chronic prostatitis is a complicated interaction of the microbiome, neurogenic, muscular, and the humoral endocrine systems. This leads to a multidimensional, and when I mean multidimensional, I mean impact at the cellular, organ, and systemic levels, and we end up with a patient with a neurogenic inflammatory pain syndrome. And I've learned that the individual clinical picture for each patient is the key to management. And have these insights helped us or helped me better manage my patients? Yes, it has. We have now gone to the point where about 80% of the patients that we manage in our complicated tertiary referral center leave happier than they came in. We may not be curing them, but we're certainly managing them better. These lessons learned have led to new treatment paradigms in chronic prostatitis, and it's a pleasure that I have Dr. Shoskis following me and I look forward to hearing his new treatment paradigms for this difficult condition. I'm not sure on the way this is set up, whether we'll have time for questions, but I'll be online if there is time for questions after Dr. Shoska's discussion. Thank you very much.
Okay. Thank you very much for the nice explanation, Professor Nickel. Now we a bit understand more about how to diagnose CPBS in our daily practice. Thank you so much. And welcome also for Professor Daniel Schutz. We're so sorry about the time differences, daylight saving in your country. Professor Daniel is one of the Cleveland Clinic urologists who concerned about CPBS and men's health. He already published a lot of research about CPBS, and today he will explain to us about management of CPBS from standard to controversies. Professor Daniel, time is yours. Thank you.
Well, thank you very much for this invitation to speak to your organization. Curtis is always a hard act to follow, but having laid out the rationale for his investigation into CPBS, I'd like now to discuss our approach to therapy, how we got here, how we do it, and what we may be doing more of in the future. So this is a very old slide. I've been showing it over 10 years, and unfortunately, I'm still showing it because not much has changed. The current standard of care in most communities is still a diagnosis based on pain between the nipples and the knees of men with some lower urinary symptoms. The rectal exam is often reported as a boggy prostate with great glee, expressing that this is actually something of significance, which it's not. And always my favorite on cystoscopy, the classic cystoscopic appearance of prostatitis, which I've yet to understand what that is. Patients have had a urinalysis and possibly a urine culture. They've always had prolonged courses of antibiotics, possibly supplemented with an alpha blocker, anti-inflammatories, or finasteride, even if their prostate is tiny. And then finally, they get referred to pain management or psychiatry. This doesn't work. When we started the first NIH collaborative trial, simply looking at a cohort of men over time at specialty centers, the 1 year treated improvement rate hovered around 17%. Well, it's fine for me to pontificate and say all this is bad, but does evidence-based medicine actually have anything better to offer? Well, as you just heard, we've only had a classification since 1996 that was syndrome-based. We've only had a validated symptom index since 1998. And the first randomized placebo-controlled trial with a validated endpoint was in 1999. There have been many small trials with positive results, but none were reproduced in large multi-center trials. And of note, even the current large NIH group, the MAP project, which is currently winding down, has had no treatment arms. So what did we learn from the early NIH group, clinical trials? It was hoped to at least have some early home runs and use what we knew worked. Well, they didn't really work. There was a 2x2 design of ciprofloxacin and tamsulosin, which was no better than placebo. A large study of alfuzacin, we knew that alpha blockers worked, was no better than placebo. Pregabalin helped with the pain, but failed the primary endpoint. And even pelvic floor physical therapy, compared to Western massage, it was better in women, but not in men. And as Curtis explained, the most likely reason for this is that we're not dealing with one disease, but we're dealing with a multifactorial syndrome in which you may have some local pain drivers in the bladder or the prostate leading to inflammation, cytokine release, which then can trigger neuromuscular factors of bladder, neck, and pelvic floor spasm, and then finally systemic neuropathic pain, allodynia, hyperalgesia, and then the maladaptive psychologic responses. And patients can be anywhere in this system. So why would one treatment be suitable for all of them? And I think that's why all the studies of monotherapy have mostly failed. It's a multifactorial condition with diverse etiologies. And so they're not going to respond to the same therapies. And right now, we don't have a validated markers to know when it's organ specific or a systemic chronic pain condition. And this is common sense. You don't treat headache in someone who has sinusitis or brain tumor with an anti-migraine drug. If you did a study of a migraine drug that worked 100% of the time, but you include people who don't have a migraine, the study will fail. Similarly, we don't treat metastatic tumors the same way we treat localized tumors. So why would this be any different in this chronic pain syndrome? Curtis introduced the idea of the UPOINT phenotyping system. And the 6 domains were specifically chosen because we know how to treat each of them. We have interventions that can help urinary symptoms, psychosocial issues, bladder, prostate problems. We know how to treat an infection. We have treatments for neurologic and neuropathic pain, and we know how to treat the muscles. So the idea is, as Curtis discussed, how to say yes or no in each of the domains, but then target multimodal therapy to what is there and don't treat what's not there. So I'd like to go in now to a practical guide to how to treat these patients using UPOINT. I want to emphasize that first you have to make that diagnosis of chronic pelvic pain syndrome. This isn't going to work if they have a kidney stone causing their pain. It's not going to work if they have recurrent UTI and true category 2. So this step 1 is figuring out that they are category 3. Once you have, then you can use the chronic prostatitis symptom index to assess symptom severity. And I want to emphasize, it does not make the diagnosis. Do not use it as a screening tool. So some of the other things that you might not normally be doing now, ask about depression, catastrophizing, ask if the pain is relieved by voiding. Could the bladder be a driver here? Ask if they have pain outside the pelvis or other pain syndromes. During the rectal exam, palpate the pelvic muscles on either side and above the prostate and see if they have muscle spasm and trigger points. This is really simple to do, and it's not subtle. Do culture the urine, including mycoplasma, ureaplasma, and culture some form of prostate source, either expressed prostatic secretions or a post-massage urine. And then check a post-void residual by ultrasound. So let's start with the urinary domain. We diagnose it by bothersome urinary symptoms, perhaps an elevated PVR. We're urologists. We know how to treat this. Alpha blockers, antimuscarinics, beta-3 agonists. We know what they do and how to use them. Dietary changes can impact the urinary symptoms. And if there is persistence of these symptoms despite these interventions, we also know how to do third-line therapies for overactive bladder. The psychosocial, does the patient have depression, helplessness, hopelessness? The treatment is not going to come from the urologist. We're not trained to do this, and that's okay, but we can use appropriate referral, and they can use antidepressants, stress reduction, or cognitive behavioral therapy. What about organ specific? Well, is there any evidence that the prostate is a symptom driver? Is the prostate itself tender? If you look at the fluid under the microscope, is there inflammation? We typically will treat this with herbal anti-inflammatories, which seem to have the strongest evidence behind them, including quercetin, bee or rye pollen, and cernalton. What about the bladder? Do they actually have evidence of interstitial cystitis? Interstitial cystitis in men, the hallmark is pain is tied to the voiding cycle. So pain improved by voiding, worsens as it fills. Some people will infuse lidocaine into the bladder, see if it goes away. And if on cystoscopy, you see Hunter lesions. You know how to treat interstitial cystitis. We will use quercetin, while pentosan polysulfate is on the guidelines. I no longer use it for the reasons that you're probably aware. Dietary changes, and if they have the Hunter lesions, we very rapidly go to cyclosporin. What about infection? Well, why are we talking about infection in someone who has category 3? If you have category 3, you still might get urethritis. And ureaplasma is positive in just under 10% of these men. Or you can get uropathic bacteria in the EPS without a UTI. Unclear significance, but it's worth a single course of an antibiotic. So in these specific circumstances, I think it's reasonable to use antibiotics. There's also this special case where the cultures are always negative, but the patient always gets long-term durable response with the antibiotics. Who am I to say no? Just be aware that the typical classes of antibiotics that we use for prostatitis, like the macrolides, the tetracyclines, the quinolones, they all have anti-inflammatory properties independent of their ability to kill bacteria. And that may be how they're helping the symptoms. Now, what about next generation sequencing? Curtis did talk about the microbiome, and now we have commercially available ways to look for bacteria. So we did a recent study where we looked at men with CPPS and did conventional cultures of urine and prostate fluid, and also next generation sequencing. All the conventional urine cultures were negative. There were 3 conventional prostate fluids that were positive. We found 10 positive by NGS for gram-negative uropathogens. Interestingly, none of them localized to the prostate fluid. They were all found in the urine as well. 9 of these patients we were able to treat with antibiotics. Only 1 of the 9 improved. So at this point, I cannot recommend next generation sequencing to diagnose a treatable infection if conventional cultures are negative. And again, I'm talking specifically in men with CPPS. Moving on to the neurologic systemic domain, do they have pain outside the lower abdomen, genitals, or pelvis? Do they have pain syndromes like fibromyalgia, irritable bowel? The therapy includes neuroleptic treatments. Amitriptyline is nice because it has some anticholinergic effects and can help with avoiding symptoms. Duloxetine, gabapentin, and pregabalin all have evidence behind them. Finally, tenderness of skeletal muscles. You diagnose it by spasm and or trigger points or tender points of the pelvic and abdominal muscles. The hallmark of therapy is pelvic floor physical therapy, particularly myofascial release. Trigger point injection can help for people who fail that. Stress reduction, muscle relaxants, and low intensity shockwave therapy. Now, proper physical therapy matters. If you just send these patients off for urologic physical therapy, we find a lot of the times they get taught Kegel exercises, which is the exact opposite of what you're trying to achieve. And we looked at this in a study. There were 82 men with pelvic floor spasm that we all recommended pelvic floor therapy. They either refused to do it, went and found their own therapist, or did it with one of our specialty therapists. Only 1 out of 9 of the patients who refused ever got better. 42% got better if they did it elsewhere, and almost 80% if they did it with specialized physical therapy. So proper physical therapy matters. What about trigger point injection? Well, we offer this to our physical therapy failures or people who plateau. In our initial experience, and we've done many more patients since, we reported on 37 patients who had up to 3 sets of injections. The mean CPSI had a significant drop. 65% of the patients reported that they improved. If you use strict NIH point criteria, it was 53%. The 3 men who didn't do the physical therapy at all and just wanted the trigger point injections, none of them improved. And complications were minimal and transient. How to inject? There's very limited data and descriptions in these syndromes. I learned this from Robert Baldwin, who published his technique in 2013. First, do a limited nerve block to anesthetize the area of the muscles. And if you're going anteriorly, you first do an ilioinguinal block, which does require ultrasound guidance. And in the pelvic, a pudendal block. You can palpate the trigger points transrectally in men, and you can do it transvaginally in women. A fine, flexible trigger point injection needle is inserted until it touches your finger or you feel the muscle twitch, and then inject an anesthetic mixture. And here's a diagram in men. Again, palpate the muscle, confirm its location, pass the trigger point needle through the anesthetized area right to your finger. What about low intensity shockwave? A lot of interest in this lately, both with the true shockwave machines and those that produce acoustic waves, which have been used in physical therapy for a long time. It's transcutaneous, applied perineally. It is painless. In the United States, it is not approved by the FDA. Most studies looking at CPPS have done it weekly for 4 to 6 weeks. There have been several randomized trials, and all of them have been positive short-term. 2 studies showed efficacy for at least a year. Unfortunately, no study phenotyped the patients, so we don't really know who had pelvic floor spasm and who didn't. And the mechanism is unclear. There's some hand-waving description of maybe it's a blood flow issue or stem cells. My suspicion with our own initial experience is that we're treating trigger points in men with pelvic floor spasm. There's a recent meta-analysis of this in Press. They included 6 randomized controlled studies, 1 without a sham. The shockwave was superior at 1 and 3 months for pain and quality of life and total score, as you can see here. 2 studies were longer term. 1 eventually lost efficacy, 1 maintained, and there was no impact on urinary symptoms or erectile dysfunction. So where do I think this is going to fit in? You know, we have a lot of limitations at the moment. We don't know the long-term durability. It's not FDA approved for this indication. And in the United States, there's no insurance coverage. And really only 1 type of protocol has been tested. And we know there's great variability between the different types of machines. But there are multiple potential advantages. It's very simple to do. It's not operator dependent. And it may help overcome poor access to specialized physical therapy services. What about acupuncture? well, it has been long used as a treatment for pain, and there have been many open label studies of uncertain robustness and no phenotyping. There have been 10 published trials comparing acupuncture to sham or to medical therapy. Most will show an improvement in total CPSI, typically driven by that pain domain, with less improvement in urinary symptoms and quality of life. But again, no phenotyping, the protocols are not standardized, and the duration is unknown. Just wanted to focus on one special group that we have dubbed spousal revenge syndrome. We published on a cohort of 8 men who developed symptoms, and they were convinced that they had a sexually transmitted infection after sexual encounter outside of marriage. And this was often protected intercourse or even types of sexual contact that you would be sure could never cause transmission of any kind of infection. And indeed, these men had all been cultured multiple times, and their STD tests were all negative. They were given antibiotics, which either gave temporary or no improvement. Our evaluation, all cultures were negative, and all of them had pelvic floor spasm. And if they agreed to treat the spasm, they got better, and many refused, still convinced that they had acquired an infection by cheating on their spouse, and none of them got better, and they moved on to the next doctor. So, does this approach work? Our first study looked at 100 patients, so number equals percent, followed for a minimum of 6 months with an average of 50 weeks. They were offered at least one therapy for each positive domain, and the only ones excluded were those who never came back, or if they refused to do any of the therapies, but they did not have to agree to all of them. And this was published back in 2010. There were 84 patients who improved, so 84% by the primary endpoint, which was a 6-point drop in total score, and 50% achieved at least a 50% drop. Interestingly, the number of positive domains or the individual therapies did not significantly alter the chance of improvement. This has now been replicated in multiple other studies. There was a large European study, 914 patients phenotyped. They used UPOINTs, adding the S for sexual side effects. They were all given multimodal therapy, treatments including alpha blockers, herbal supplements, antibiotics. 6-month follow-up, 78% of the patients better. A study published from China with 140 patients. Similar therapies, they used Cernalton for organ-specific and biofeedback for the pelvic floor spasm. 6 months follow-up, 75% of the patients better. A recent study from Russia, 110 men that were actually split between multimodal therapy and a control group. The groups were similar for age and CPSI. All domains improved with therapy, and nobody in the control group improved. The numbers look almost identical, so it's an interesting finding, but certainly significant improvement using multimodal therapy with UPOINT. So to summarize, the UPOINT system can provide a simple and valid way to phenotype these men in a clinically relevant way. Multimodal therapy based on this phenotyping system has a very high chance of patient improvement, certainly an improvement over that 17% that we saw decades ago. But we still need to help that 20 to 25% of men who don't get better using our approach, whether it's going to be through more accurate phenotyping or better therapies for each domain remain to be seen. Thank you very much.
Okay, thank you very much for Professor Daniel Schultz for the nice presentation. May I conclude? Once again, it is common in our daily practice, but it is still a bit confusing, and we should use our urologic finger to make introduction. Okay, maybe the first question, is there any question from the floor? Sorry. Okay, I don't see any question from the floor. Great. Okay, maybe I would like to ask the first speaker, Dr. Wirya. It is confirmed that in Indonesia, and influencing for the andrology services such as family planning and IVF that you already mentioned, and also vasectomy, one of the simple operation. Actually, it's very simple operation, but we should be taking carefully to
Dr. Ricky. Dr. Ricky. Dr. Widi, can you hear me?
Yeah, I can hear you, Dr. Wirya.
Yeah, but I cannot hear Dr. Ricky at all. I cannot hear his question. Sorry.
Yeah. Okay, so maybe I will replace the Dr. Ricky for a while. So I have a question for the Prof. Nickel. So do you always evaluate every patient with the suspicion of the prostatitis with the UPOINT principle? I mean that we have to evaluate everything in UPOINT in every session. So or maybe you just evaluate to diagnose the CPPS with the urine culture after the post-massage, and then maybe from the symptoms. So how about it? Sorry, your voice is not, sorry. Halo, Dr. Ricky.
hello.
Yeah. While you are away from the Zoom, I replaced.
I'm so sorry.
Before. It's okay. I already have one question to Prof. Nickel. So, but his audio, I think there is some problem because we cannot hear his audio. Sorry, Prof. Nickel, we still cannot hear your voice. Yeah, it's okay.
There is also internet problem in my house because the electricity is turned down in all Bandung area.
So, Dr. Ricky, mind if you repeat your question, please? I try to answer.
Can you hear me now?
Okay, thank you.
Yeah, we can hear you, Prof. Nickel.
Okay, well, I did hear your question, and it was a very good question. In clinical practice, we find that the UPOINT was a way to categorize things, but it's what you do anyways when you see a chronic prostatitis patient or somebody with chronic pelvic pain syndrome. You do not have to use UPOINT specifically, but you certainly can go over the same thing. So it's important for you to go over the symptoms, the infection, to examine the prostate to see if it's organ specific, to examine the pelvic floor, to look at psychological impact on the different patients. And the urinary symptoms. So a good analysis or evaluation of a patient will cover all those domains. And many physicians and urologists have told me that they do that anyways, even when they don't use UPOINT. In fact, they are. It's just a good way to look at the overall clinical picture. And the UPOINT just allows us to put it into sort of research studies. Basically, the main point is that you need to look at all those domains when you're evaluating a patient. Those 6 domains plus probably sexual dysfunction.
So I think we as urologists should be as the first line to screen the UPOINT problems, right? Or maybe every patient with the suspicion of the prostatitis, you always consult to another multidiscipline team, or you just be the first line that you have to screen all of them?
I would say that 80% of patients that are sent to our tertiary referral center, I do not send on. I'm sort of the last place they come. So the only ones I refer on is occasionally difficult patients that need the pain clinic for neurogenic pain management, or patients that require significant psychological support, such as cognitive behavioral therapy, or patients that need appropriate physical therapy for their pelvic floor. So those are my 3 main referrals: pelvic floor physiotherapy, a psychologist who understands pain, and a pain clinic that understands neurogenic pain and does not treat the patients with opioids. So I try and steer them away from a pain clinic that uses opioids for the treatment of neurogenic pain.
Okay, thank you. So I think it's
I have one question for you, Professor Nickel. So, what is the role of microbiome in your opinion for the prostatitis, for the chronic prostatitis? The microbiota.
I missed the intervention. What did you say?
Well, what is the benefit of, what is the role of microbiome to prostatitis, to chronic prostatitis syndrome?
What is the impact of the microbiome or infection? Is that what you're saying?
Yes.
Yes. Well, as both myself and Dr. Shoskis say, when patients present, somewhere between 5 and 10%, we will determine that there is a potential bacteria or microorganism that could be implicated. And we do treat those patients to be sure we're not missing any infection. Most of the patients I see, and I'm sure Dr. Shoskis as well, have already been treated with multiple courses of antibiotics by their primary care physicians or other specialists and urologists before I see them. But I will still treat them with antibiotics if I find an organism that might be implicated. The problem is many of these patients do not respond to antibiotic therapy, but and that's why they've been sent to me, but I still look for infection. I also, like Dr. Shoskis, have been involved in using next generation sequencing to determine whether or not antibiotic therapy directed against bugs that we don't culture but that might be implicated is worthwhile. And the jury is still out. Dr. Shoskis has published on 9 patients, and only one of them really benefited from that, which is probably what we'd see if we just gave everybody empiric antibiotics. So there is some concern that we may be over-treating patients with antibiotics with the chronic prostatitis syndrome, even based on cultures or the new next generation sequencing approach.
Thank you.
Okay, thank you. So I think Dr. Ricky is already with us. So I think the meeting will, I will give to Dr. Ricky. Thank you.
Thank you so much. I'm so sorry about the internet connection. It's a problem here nowadays. Okay, Professor Nickel, I think there is one question that's very interesting regarding the hematospermia. Is it already being discussed or not? Not yet?
Not yet.
Well, no, Dr. Shoskis did mention hematospermia as a clue that the prostate is involved, and I agree with that. Most hematospermia in young and middle-aged men is benign condition, likely representing prostate inflammation, it's important to rule out other disease. But to me, hematospermia means that we should focus, among other things, on the prostate gland. We need to investigate it, and depending on the level of concern, that would be with PSA, if they're of the certain age group that prostate cancer is of concern, some sort of imaging modality, and I would use at best ultrasound and occasional cystoscopy on these patients to reassure the patient and myself that that we're not dealing with anything else. But I see Dr. Shoskis is on, and he may have some comments, and since he did raise the hematospermia.
Okay. Sorry, Prof. Soskes, you are
Danny,
still...
Danny, you're still muted.
Yeah, sorry, I'm not seeing the specific question about hematospermia.
The question was just in general, how does hematospermia,
Yes.
what part does hematospermia play as in terms of diagnostic and therapeutics?
I mean, not much. Certainly, when you have a true urinary tract infection or true bacterial prostatitis, that can often be a cause of hematospermia. But the vast majority of men who present with hematospermia don't have those things, and it's really just a nosebleed of the prostate and requires very minimal diagnostic intervention. It certainly does not, need a lot of other workup unless indicated for other reasons.
I concur with Dr. Shoskis, but I certainly do like the nosebleed of the prostate. That's a good analogy, Dr. Shoskis.
Hello, Dr. Ricky. Yeah, I think his signal is so bad. Okay, I have a question for maybe for Prof. Soskes. You said that the multimodal therapy in UPOINT principle, so many options that we can give to the patient. But do you have any minimal requirements that maybe that not all of the hospital have the whole of the facilities that like you said in your presentation, but is there any minimal requirements that there is the main therapy that we can give to every prostatitis patient for us, at least with this therapy? Do you have any suggestion for the multimodal therapy like that?
Sure. Well, I think for each of those 6 domains, I did give multiple options, and I would be surprised if people don't have access to at least one of those. I mean, we know how to treat the urinary symptoms, organ specific. There are various anti-inflammatories, including quercetin. Infections, we all have the antibiotics, the neurologic, systemic. I know not everyone has the same neuroleptic drugs commonly used, but between amitriptyline, gabapentin, duloxetine, those are great options. The trigger point, and the reason I focused on it is, if you're running a specialty clinic, you end up seeing a higher proportion of men with pelvic floor spasm, I think, than in the general CPPS population, simply because the simple infections and voiding dysfunctions have been weeded out by the first 5 urologists that they've seen. And it's the pelvic floor spasm that often is the thing that hasn't been picked up. And that's why, even though the physical therapy is effective, again, at our place up to 80% of the time, we've tried to come up with other creative ways for the remaining 20%. So even if you don't do trigger point injection or shockwave, simply getting a correct diagnosis that the muscles are a pain driver and addressing those muscles as best you can is going to go a lot further than putting them on antibiotics. I know Curtis has had a challenge in Canada in the past getting skilled physical therapy because it I believe was not covered by the health plan, but hopefully that's changed.
Well, what we're doing right now, Danny, and it's a funded study trial, is using a physiotherapy group practice, where we have a group of 5 to 10 individuals, and we're doing this in females, because they do group therapy much better than males. And we're doing group physiotherapy teaching sessions and comparing that to individual therapy, both on as a cost-effective basis. When we tried it with males, we just could not get males into group therapy sessions. In answer to the previous questions about multimodal therapy, we have updated a network meta-analysis on treatments that we had published a number of years ago, and looked primarily a combination multimodal therapy. And when you tease out the results, the best therapy available, alpha blocker, anti-inflammatory, analgesic, and muscle relaxant. My internet is unstable now as well, I see. The problem with that is it sort of, we've not found it as helpful to give every patient the same therapy. And Danny Shaskas has really explained the differences in treatment results when you tailor your multimodal therapy and individualize it for each patient. That is the way that has led to very successful treatment. But not only that, patients are happy and understand that you are tailoring a specific treatment for them. And when it's explained to them that way, that they're being treated very specially, they do better. They understand how you're trying to help them. And I think that's, for me, that has been the key in the last 10 years, ever since Danny and I sat at the back of a room once and talked about how we were going to improve the diagnosis and management for these poor men when all our clinical trials were failing.
Okay, thank you, Prof. Nickel and Prof. Shaskas. So there is a question from the floor related to our discussion before from Dr. Imade Ariput Saputra. How do we follow up the treatment of each UPOINT domain that we already give to the CPPS patient? Maybe you have any like 1 month or 2 months or whatever. So how many months or weeks that we have to evaluate every treatment?
I think that depends on the treatment. If the patient is only having bothersome urinary symptoms with a weak flow, and you use an alpha blocker, you would expect that alpha blocker to work within a week or two. If you're using, beta-3 agonists, it may take a month. If, however, they have pelvic floor spasm and I send them for physical therapy, I'll usually see them back in 3 months, because it often's taken them years to get into this mess with their muscles, and so it can take a little longer for it to relax. So much like the therapy is tailored, the follow-up is really kind of driven by the choices. I mean, again, if you were going to give them an antibiotic for 2 weeks, you wouldn't wait 3 months to see them back. So for me, again, because a lot of my patients do have muscle issues, I see them back at 3 months. But certainly, if it was an antibiotic and an alpha blocker, I would see them back sooner, because I would expect it to be effective more quickly.
Okay, so yeah, thank you for the answer. And then we already have a lot of questions now. Maybe it is about the antibiotics from the Dr. Gerhard Renaldi. So when antibiotics are indicated, do you use them long term or 1 month at least? Or are there any shorter term strategies? So how do you evaluate the outcome? Sometimes the symptoms do persist even in the absence of clear infection signs. So maybe Prof. Nickel or Prof. Shaskas?
I just want to make a comment about the prolonged antibiotic, because, this has entered the minds of people treating prostatitis around the world, that anyone that you suspect of having any of the 4 categories needs to go on 6 weeks of antibiotics. And there's absolutely no shred of evidence for that. If you're trying to treat true chronic bacterial prostatitis, yes, 6-week course, even as long as a 12-week course may be necessary to eradicate the bacteria. But if you're treating a UTI, or if you're treating someone with CPPS who happens to have a positive culture, I think 6 weeks is massive overkill, and you're really subjecting that patient's microbiome to a big hit. Curtis, what are your thoughts on duration?
Yes, one of the main impacts of long-term antibiotic therapy, as Dr. Stosky's alludes, is it pollutes our body. It's poison to not only the bad bugs we think we are treating, but also the population of good bacteria that are keeping us healthy. It impacts significantly the bowel microbiome, which is so important for our general health and well-being. But we believe more and more we are seeing an abnormal ecology in the lower urinary tract. We call it dysbiosis in patients who are treated with long-term antibiotics. And this dysbiosis of bacteria, which usually occurs during or after the antibiotics have ceased, may in fact be propagating the disease rather than helping to cure it. So I also have been very focused in the use of antibiotic therapy. In the last year, I have become, as many physicians have, become very concerned about the fluoroquinolones, particularly now that we're seeing that patients who have prolonged fluoroquinolones, that's over 4 weeks, have a higher incidence not only of tendon rupture, but they have irreversible neuropathies. They have psychological problems such as depression and suicidal ideation that may or may not be because of gut microbiome differences. And unfortunately, we're seeing a higher incidence of aortic dissection in these patients. So I tend to use either the older antibiotics, such as trimethoprim, the tetracyclines, such as doxycyclines, the macrolides, such as clarithromycin, and I tend to use more in the last year or two, reasonably successfully, that old antibiotic from the 1960s, fosfomycin. All of those are the main go-tos I use. If I do use fluoroquinolones, such as levofloxacin or ciprofloxacin, I document the risk-benefit discussion that I have with the patient, because right now we are involved in North America with so many lawsuits with the fluoroquinolones and side effects, and the defendants are urologists who are treating prostatitis in many of these cases.
Okay, so thank you, Prof. Nickel and Prof. Soskas. So we still have some questions. So regarding to our discussion about the antibiotics from Dr. Irfan Wahyudi, he asked, how to know in treating bacterial prostatitis that we can stop antibiotics? From the symptoms, or maybe from we have to evaluate the urine culture, or how? Maybe Prof. Soskas?
Well, if you're treating a chronic bacterial prostatitis, which we have not discussed today at all, by definition, the patients are not going to be symptomatic, because with true category 2, you have symptomatic urinary tract infection, and in between those symptomatic episodes, you recover the same bacteria from the prostate. So the goal of the prolonged therapy is not suppression of symptoms. The goal of the prolonged therapy is eradicating the bacteria in the prostate. If you're using prolonged antibiotics for symptom improvement, I would suspect that what you're truly getting is the anti-inflammatory effects of those antibiotics. And typically, if you stop that antibiotic, we know the antibiotic hangs around in the prostate for up to 2 weeks. So when patients stop the antibiotic and their symptoms come back 2 days later, you've proven that it's the anti-inflammatory effects and not the antimicrobial effects. So, chronic bacterial prostatitis is a very different condition, and I'm not using symptoms to monitor. I'm using lack of recurrence of the infection or reculture to assess that.
Just to add a little bit, and I know Danny has really added to this field, in patients who we've had trouble eradicating bacteria in men with recurrent urinary tract infections with a nidus in the prostate, it is sometimes the prostate calculi are implicated. And some of the best references are actually Dr. Shosky's in this regard. And the prostatic calculi can be a very difficult, infected prostatic calculi can be a very difficult clinical scenario in which you can have patients on long-term antibiotics and you'll never eradicate the bacteria, you'll just suppress them. And those patients may require surgery. But if patients have chronic pelvic pain syndrome and you see prostatic calculi, it does not necessarily mean that antibiotics are going to be of any benefit. They're unlikely to be. And it's not really clear whether surgery and removing those stones will have any impact on the patient's symptoms, except perhaps to maybe make them worse. Now, in my opinion, as far as the patient with chronic pelvic pain syndrome, no recurrent urinary tract infections, but you grow a bug, let's say Klebsiella or E. coli in the urine or in the prostatic secretion or the post-prostatic massage urine, and you want to use antibiotics because the patient is naive, I would stop that antimicrobial therapy at 4 weeks. We actually did a study where we looked at 12 weeks of therapy in these patients with chronic pelvic pain syndrome, no recurrent UTIs, and these were empiric antibiotic therapy. Any patient who did not improve by 4 weeks did not have any further improvement by adding 8 further weeks of antimicrobial therapy. So I think we have a cutoff of not giving patients more than 4 weeks. For patients that are improving, we really don't know how long to continue it, only that, again, antibiotics are poison for our good bugs and probably for us as well. And we should really be using them carefully and looking at antibiotic stewardship in these men at this time.
Okay, to both of the speakers, there is one question about PSA. Is there any value to measure PSA for this prostatitis? Thank you.
For CPPS, no, unless otherwise indicated by age or physical exam.
Okay.
I agree with Dr. Shoskas that PSA is irrelevant unless you're using PSA just to screen a population for prostate cancer. However, ordering a PSA test when a patient has a bacterial prostatitis, the acute episode, or chronic bacterial prostatitis with a recurrent UTI, you do not want to do a PSA, or it's going to lead you down a rabbit hole of biopsies and things. So after an acute urinary tract infection, either bacterial prostatitis or a lower urinary tract infection, we've seen elevated PSAs last for 6 months and much longer. So it's better not to do a PSA. If you're going to use a PSA for screening prostate cancer, it's best to wait a minimum of 6 weeks until such time as the PSA would normalize. But I agree with Danny, there's no real rationale to use PSA as a part of a workup with a patient for CPPS. PSA is used to screen for prostate cancer, and that's a different scenario.
Okay, thank you very much. Dr. Nicol, one more question from our urologist in here. I saw your research focused mainly on the microbiome profiles of the prostate. Have you ever looked at the proteomics of miRNA, providing studies of the different categories or patient phenotype? I'm just wondering whether the C81 patient would have a distinct inflammatory milieu compared to C83 patients, or maybe no difference. This is from Dr. Rinaldi.
That's an excellent question. And as we say, it's way above my pay grade and my understanding. But I do believe that those type of studies will help better in the future understand the etiology and pathogenesis, number one. Number two, will help us better categorize patients that may have inflammation in the prostate that's causing the pain. And three, they may help us focus treatment better in the future. Unfortunately, I have no expertise in the field, but do believe that, looking at aspects other than just the microbiome will help us find biomarkers of disease pathogenesis and may lead to targets for treatment.
Okay. One more question, maybe, I don't know whether it is already answered or not, whether it is already discussed or not, I'm sorry. Professor Nico, is there a place for antifungal for CPPS non-responsive to multiple antibiotic treatments? What do you think?
That again is a very perceptive question, but we have found very little fungi in studying CPPS patients, except for those that have immunocompromise, HIV patients, cancer patients, or other types of immunosuppression, or patients that have been overtreated with antibiotics. Then we sometimes see fungi. In the latter patients, I usually find that taking them off antibiotics and let Mother Nature take care of things, the fungi, will usually go away. What can I say for the immunosuppressed patients? Well, yes, judicious use of antifungal agents can be very helpful for the very rare patient who has an active fungal prostate infection. And I have seen them, and they are very difficult to treat because the patients are usually, like I say, immunocompromised. That's a very pertinent question.
Okay. This is another question also for both of you. Do the result of 2 glass tests or 4 glass tests would much influence your prostatitis treatments, since these tests are not routinely performed in Indonesia? Should we perform the tests or routinely or what? Thank you.
These tests work extremely well when the patient first presents, and they're very accurate if you can do the test before the patient has been put on antibiotics. The pre and post massage test is so simple because I know in Indonesia, you do 2 things. You do the midstream urine culture and you do the DRE or prostate examination. All you have to do following the prostate examination is put a little pressure on the prostate, and then after, the patient just voids 10 cc's and picks up any prostate fluid that's in the prostatic urethra. So it's very, very simple to do. It's not that helpful in patients, I found, who have been on multiple courses of antibiotic therapy. Those patients usually always have negative 2-glass tests, or 2-glass tests are very hard to interpret. So they've not been very helpful in the type of patient that I've seen. However, the urologists who refer to me are now doing 2-glass tests when they first see the patient, and that's when it's very helpful. The first encounter with a first urologist.
Okay, thank you very much. So I think we should perform the test routinely, to diagnose this. Okay, Dr. Widi, maybe, is there any question from the participants? Dr.
No, I think that's the last question from the audience.
So Dr. Widi, maybe.
Thank you very much for inviting us. I do know that Danny Shaskas was called away to clinic, but I'm sure he would like me to thank you for him. We both appreciated this chance to present and talk to our friends in Indonesia, and perhaps someday we will come and see you in person.
Yeah.
Yes.
You're very welcome.
We would like. Yeah, we're looking forward for you coming to Indonesia when the pandemic's over.
Okay. Thank you very much. Bye now.
Bye. Okay, thank you very much. I think this is the end of our discussion today about the CPPS from the ICU andrologic session. Thank you very much for joining, and I hope that we do understand now about the CPPS and how to treat the CPPS properly. Bye. Thank you so much. We're sorry for the connection.
Thank you, Dr. Ricky, Dr. GWK.
Thank you.
To all
Terima
the
kasih, Dr. Widi. Ricky, thank you.
Thank you.